Hello everyone, welcome to UCAP 2025. My name is Shanggar Kuppusamy and I'm a consultant urologist at University Malaya Medical Center, Kuala Lumpur. My topic for today is on intravesical therapy from BCG to some innovative strategies. Let's begin with some context on non-muscle invasive bladder cancer or NMIBC. NMIBC accounts for approximately 70 to 80% of all newly diagnosed bladder cancers. The disease has a notoriously high risk of recurrence, with about two-thirds of patients experiencing at least one recurrence during their lifetime. More concerning is that up to 20% of high-risk NMIBC cases will progress to muscle-invasive bladder cancer or MIBC, which carries a significantly poorer prognosis and often requires radical intervention like a radical cystectomy. This high risk of recurrence and progression is why long-term intravesical therapy plays a central role in management. However, even with standard intravesical agents like BCG and mitomycin C, recurrence rates remain between 30 to 50%. Clearly, this underscores the urgent need for more effective and innovative strategies, either as alternatives to or enhancement of traditional intravesical therapy. So, why do we use intravesical therapy? The key advantage lies in its ability to deliver therapeutic agents directly into the bladder lumen, where residual tumor cells are most likely to remain after transurethral resection. This targeted approach ensures high local drug concentration at the site of disease with minimal systemic absorption, thereby reducing systemic toxicity. The primary goals of intravesical therapy are twofold. First, to prevent tumor recurrence by eliminating microscopic residual disease and free-floating tumor cells. Second, to prevent progression to muscle-invasive disease, particularly in high-risk patients. Among the agents most commonly used are mitomycin C, a cytotoxic chemotherapeutic agent, and BCG or Bacillus calmette-guerin, which acts as an immunotherapy. Both have established roles depending on the patient's risk profile and treatment response. Now let's take a closer look at BCG. BCG is a live attenuated strain of Mycobacterium bovis. While originally developed as a vaccine for tuberculosis, it was repurposed for bladder cancer treatment. The first successful human use of intravesical BCG was reported by Morales et al. In 1976. Since then, it has become a mainstay in the treatment of high-grade Ta, T1 tumors and carcinoma in situ, also known as CIS. BCG exerts its anti-tumor effects by stimulating a robust local immune response. The mechanism of action of BCG is still poorly understood, but it is postulated that when BCG is instilled into the bladder, it interacts with the urothelial lining, leading to recruitment and activation of immune cells such as macrophages, neutrophils, dendritic cells, natural killer cells, and T lymphocytes. This cascade results in the release of various cytokines and cytotoxic mediators that collectively help eliminate residual tumor cells. This immune-mediated mechanism sets BCG apart from traditional chemotherapeutic agents, and it's precisely why it's so effective in high-risk immunogenic tumor subtypes like CIS and high-grade tumors. To illustrate how BCG is used in clinical practice, let me briefly present a patient scenario. We have a 52-year-old gentleman who presented with painless frank hematuria, which is a classic red flag symptom for bladder cancer. Flexible cystoscopy revealed a bladder tumor, and staging with CT urogram showed no upper tract involvement or distant metastasis. He subsequently underwent a transurethral resection of bladder tumor or TURBT. During the procedure, multiple lesions were identified in the bladder, as shown in the image in the slide, with the largest measuring approximately 2 to 3 centimeters. Histopathological examination confirmed high-grade urothelial carcinoma with the important finding of lymphovascular invasion. Fortunately, No invasion into the detrusor muscle was seen in the initial specimen. Given the presence of high-grade features and lymphovascular involvement, it was critical to perform a second-look TURBT as per established guidelines, especially since no muscle involvement was present in the first resection. The second resection reconfirmed absence of muscle invasion, which definitely classifies this case as high-risk non-muscle invasive bladder cancer, T1 high-grade LVI positive. What would we do next? What we would do next is risk stratification. Management decisions in NMIBC hinge heavily on risk stratification. The EAU guidelines classify patients into four risk groups: low, intermediate, high, and very high risk. This classification is based on tumor stage and grade, presence of carcinoma in situ, tumor size, number of tumors, and recurrence pattern. Tailoring therapy based on risk is crucial. Low-risk patients might require only a single dose of intravesical chemotherapy, whereas high and very high-risk patients, like the gentleman in our case, warrant more aggressive therapy, most often with BCG. To personalize the risk factor, the EAU offers a validated online tool, which is the 2021 Risk Group Calculator, freely available at www.nmibc.net. This allows us to enter the patient-specific variables and obtain the individualized estimates for recurrence and progression. In our patient's case, who has high-grade T1 disease with lymphovascular invasion, the calculator estimates a 14% risk of progression to MIBC at 10 years if BCG is not administered. Specifically, 3.5% at 1 year, 9.6% at 5 years, and 14% at 10 years, as I mentioned earlier. These numbers highlight the critical role of early, effective intravesical therapy to reduce progression risk. BCG remains the gold standard for treating high-risk non-muscle invasive bladder cancer, particularly in patients with high-grade TA, T1, and CIS. The strength of this recommendation comes from robust evidence, particularly from a meta-analysis by Sylvester et al., which pooled data from multiple randomized controlled trials. This analysis showed that BCG with maintenance therapy significantly reduces the risk of progression in both high and intermediate risk tumors. To give you a sense of the impact of what I just said, tumors progressed in only 9.8% of patients treated with BCG, compared to 13.8% in the control group, which included patients who received TURBT alone, TURBT plus intravesical chemotherapy, or TURBT with other types of immunotherapy. This actually translates to about 27% reduction in the odds of disease progression with BCG maintenance treatment, which is a clinically meaningful benefit. This is why all guidelines strongly support BCG with a maintenance schedule for appropriate patients. Now, let's talk about how BCG is delivered, which includes both induction and maintenance phases, tailored to the patient's risk category. For high-risk NMIBC, the most widely accepted protocol is from the Southwest Oncology Group. It involves an induction course of 6 weekly intravesical instillations, followed by 3 weekly instillations at months 3, 6, 12, 18, 24, 30, and 36, giving a total treatment duration of up to 3 years. For intermediate risk patients, the recommendation is to provide the same 6 weeks induction, followed by a shorter course of maintenance, typically 3 weekly installations that stops at 1 year duration. The importance of this maintenance approach is backed by pivotal trial by Odens et al., which demonstrated that 3 years of BCG maintenance significantly reduced recurrence compared to 1 year, particularly in high-risk patients. Ultimately, the duration and intensity of BCG therapy should align with the patient's risk profile. When starting intravesical BCG, it is essential that patients receive clear instructions to ensure both safety and treatment effectiveness. I apologize for this busy slide with a lot of instructions in the patient advice leaflet, but here are the key points we routinely advise. Before the treatment, confirm there's no active UTI, fever, or visible blood in the urine, as these are contraindications. Also, avoid traumatic catheterization. After the instillation, patients should retain the BCG in the bladder for about 1 to 2 hours. For the first 6 hours post-treatment, they must void while sitting to prevent splashing and add undiluted bleach to the toilet after each urination, letting it sit for at least 15 minutes before flushing. As for personal hygiene, hands and genital area should be washed thoroughly after each urination. At home, they should avoid sexual activity for at least 1 week or use condoms if intercourse resumes. Hydration can be resumed after the 6-hour post-treatment window. What are the warning signs to look out for? Patients must be educated to report symptoms such as fever above 38.5 degrees Celsius, persistent urinary symptoms, or any signs of systemic infection like chills or joint pains. This may indicate BCG infection or intolerance. In short, good patient education is key to minimizing risks and ensuring treatment compliance. While BCG is highly effective for managing high-risk NMIBC, it's not without side effects. Understanding the spectrum of adverse events is crucial for proper patient counseling, monitoring, and management. We can group BCG-related side effects into several categories. Local effects are the most common and include dysuria, frequency, urgency, and bladder discomfort, essentially symptoms of chemical cystitis. These usually appear after a few instillations and are typically self-limiting. Systemic symptoms such as low-grade fever, malaise, and arthralgias may occur in up to about 20% of patients. They also tend to resolve within 24 to 48 hours. Serious infections are rare, seen in less than 5% of cases, but can be life-threatening. These include disseminated BCG infection or BCG sepsis, pneumonitis, and granulomatous hepatitis. These require prompt treatment with antituberculous drugs and often cessation of BCG. Overall, most patients tolerate BCG well, but vigilance is essential, especially during the first few weeks of therapy. Educating patients to report persistent symptoms, high fever, or systemic signs early helps prevent serious complications. Follow-up in NMIBC is just as important as the initial treatment because of the high recurrence rates and progression rates. This table, adapted from the EAU guidelines, provide clear recommendation for risk-adapted surveillance. For example, in a high-risk patient, such as the gentleman as we discussed earlier with high-grade T1 disease and lymphovascular involvement, follow-up is more intensive with cystoscopy and urine cytology every 3 months for the first 2 years, then every 6 months until 5 years, and annually thereafter for life. In high-risk patients, upper tract imaging, example CT scan, is also recommended periodically, usually at 1 to 2 year intervals, or sooner if clinically indicated. Ultimately, the goal is to catch recurrences early while they are still superficial and to intervene before any progression to muscle-invasive disease. BCG is not without its limitations, and understanding this is essential for effective patient counseling. Firstly, we need to recognize the different categories of BCG failure, like BCG refractory disease, BCG relapsing conditions, and also BCG unresponsive diseases. Secondly, while BCG is generally well tolerated, there is a risk of toxicity and intolerance. Serious systemic complications, like I mentioned before, like BCG sepsis, occur in less than 5% of patients. And the good news is that with timely recognition, they can be treated effectively in almost all cases. Another significant limitation has been BCG supply shortages, which have impacted treatment availability worldwide. Major disruptions occurred in 2014 and 2019 prompting guideline bodies and institutions to revise their protocols, prioritize high-risk patients, and even explore alternative therapies. One of the key challenges in managing NMIBC is defining treatment failure accurately, especially in the context of BCG therapy, because it determines whether further bladder sparing treatment is possible or whether we need to consider more radical options like cystectomy. It's important to recognize that up to 40% of patients will ultimately fail BCG treatment, making this a common and clinically significant scenario. To guide our next steps, the failure needs to be clearly and consistently defined as we use these three main subcategories. Number one, BCG refractory. This refers to persistent high-grade disease despite adequate BCG, whether that's after induction alone or after both induction and maintenance. These patients are considered unlikely to benefit from further BCG challenge. BCG relapsing. Here, the patient initially achieves a complete response but develops a recurrence after a disease-free interval. Depending on the timing and risk profile, additional intravesical therapies may be considered. Thirdly, BCG intolerance. This applies to patients who cannot complete the full course of BCG due to adverse effects or complications. These patients may not have had an adequate exposure to assess true response, and treatment decisions must be individualized. Having a precise definition not only helps in clinical decision making, but also ensures patients are eligible for appropriate trials, for example, and guideline recommended salvage strategies. Now, let's look at bladder preserving alternatives for patients who either cannot undergo radical cystectomy due to significant comorbidities or refuse it despite medical advice. These approaches are typically guided by weak recommendations in current guidelines, reflecting limited or evolving evidence. Still, they offer valuable options in select, well-counseled patients. Here are the key strategies. HIVEC, which is hyperthermic intravesical chemotherapy. This method combines intravesical mitomycin C with controlled heat, usually around 43 degrees Celsius. Hyperthermia enhances drug penetration and cytotoxicity, especially effective for papillary tumors. Intravesical chemotherapy. Gemcitabine and docetaxel, either as single agents or in combination, are increasingly used, while off-label studies suggest moderate efficacy with acceptable tolerability. The other option is electromotive drug administration, EMDA. This technique uses a mild electric current to actively drive drugs like mitomycin C or even BCG deeper into the bladder wall. It improves the drug absorption and has shown promise, particularly for intermediate and high-risk NMIBC. BCG plus interferon alpha has also been tried. This combination may offer synergistic immune stimulation and can be considered in patients with low volume recurrence or partial BCG response. However, its efficacy is inferior to standard BCG. Next is photodynamic therapy, PDT. Here, a photosensitizing agent such as chlorine E6 or ALA is instilled into the bladder. The bladder is then illuminated with a specific wavelength of light, activating the agent and causing selective cancer cell destruction. While still experimental in many regions, PDT is a promising non-surgical tool. Overall, these therapies are not curative for most patients, but can be useful in delaying disease progression or controlling localized disease when cystectomy is not feasible. The key is careful patient selection, informed consent, and close follow-up, ideally within a multidisciplinary setting. As we begin exploring alternatives to BCG, it's essential to be mindful of several important caveats, both in terms of evidence quality and practical application. Remember, the gold standard for BCG failure is still radical cystectomy. I repeat, gold standard for BCG failure is radical cystectomy. Okay, so what are these caveats? First, most of these regimens are not standardized. Their use is often based on single institution experiences, phase 2 trials, or retrospective studies, rather than robust, multi center randomized data. Off label use is common, particularly with agents like gemcitabine, docetaxel, and various combination regimens. While these can be effective in select patients, they lack regulatory approval for NMIBC, and their adoption requires informed consent and careful follow-up. In contrast, combination strategies, for example, gemcitabine plus mitomycin, BCG plus interferon, or hyperthermic MMC, tend to yield better response rates and may offer a middle ground for patients who are not ready for radical surgery. A key principle across all regimes is the importance of maintenance therapy. Without it, even effective induction responses often fail to sustain over time. Lastly, it's critical to remember that many of these alternatives are still being evaluated. We urgently need more prospective trials to clarify their role, particularly whether they can offer comparable long-term outcomes to early radical cystectomy, which remains most definitive curative option in high-risk BCG unresponsive disease. So, while alternatives are promising, they should be used judiciously and within an evidence-informed framework. Coming to my last slide to summarize my presentation with some key take-home messages. Firstly, intravesical therapy is the cornerstone of bladder preservation, with BCG being the gold standard. Patient selection, education, and safety precautions are key to optimizing BCG outcomes. BCG failure, you must remember, is not uncommon. And when we are dealing with BCG failure, radical cystectomy remains the definitive gold standard treatment for any BCG unresponsive disease. Many salvage regimens are not standardized and are used off-label, and ongoing trials and novel agents represents the future of intravesical therapy. With that, I thank you for listening, and I'm looking forward to meeting all of you at UCAP 2025. Goodbye.